So, in the US, we feel that there's about 350 million people, so as to speak, and about 70 million of those have sleep disordered breathing. We feel about 5 to 7 million people exist today with heart failure, and then there's a big correlation in between where we have a bunch of patients who have both sleep disordered breathing and heart failure. And why is this so? Because both the disease states have a very similar predisposing factor, same patients, similar pathophysiology. If you take a look at this, this is what I call the house of disease patient. It's a patient with hypertension, hyperlipidemia, insulin resistance, and a whole bunch of pathophysiologic states at a microvasculature level. If you look at obstructive sleep apnea in its prevalence for other disease states, you can see it being present in patients with hypertension, in patients with heart failure, diabetes, patients with strokes in various percentages. If you look at heart failure, you have patients with sleep apnea who have repeated oscillations. This is oxygenation state, and you can see dips from 100% down, each is 5% range. So it can go down very severely. This is a case of severe sleep apnea. And these cause oscillations in sympathetic nerve traffic, causing changes in blood pressure and heart rate. And these effects carry on throughout the day, not just while the patient is sleeping. In fact, we were one of the first groups to demonstrate that sleep apnea can happen during even awake states. And we'll talk about it as we keep going. But this is a nice presentation by Somers, where they showed that there is sleep apnea here and there is sympathetic nerve activity that increases and blood pressure that correlates in terms of oscillations. If you look at measurements of norepinephrine, you can see patients with sleep apnea have higher norepinephrine levels. And this is basically what happens to patients with heart failure. So it's the same similarities. Sympathetic nervous system is activated, the vagal nerve, there is withdrawal, there is all sorts of stuff which is same, myocyte necrosis, apoptosis, the beta receptor downregulation, and myocardial ischemia because of altered loading conditions. So if you look at it in different ways, there's heart failure causing all of this down here, there's sleep apnea causing all of this, and then a combination which is described as central sleep apnea or changed dose respiration. If you look at the prevalence, different investigators have shown different prevalences, but it can range anywhere from 50 to 70% right here in terms of sleep apnea prevalence in heart failure patients. So if you have a patient with heart failure, there is more than a 50% chance that they have sleep apnea. So it is very, very important to at least consider testing them for sleep apnea, because in today's day and age, you can test and treat these patients. Now, there's the syndrome of acute heart failure and chronic heart failure, and we'll see how it makes a difference in these patient groups when we talk about sleep apnea. So, in the big scheme of things, heart failure is a growing subspecialty. There's about 500 heart failure board certified heart failure cardiologists in the United States right now for about 5 million patients. So as you can see, there's a big unmet need because the patients are just piling up. If you look at the morbidity, at 30 days there's a 20% readmission rate, and this is a very good readmission rate. At 6 months there's 50% readmission rate, and this is at the top hospitals in the country. If you look at mortality, it can range as high as 60 to 80% at 5 years. So this is a very, very morbid state. This is just regular heart failure. If you look at how much money we spend we spend about $40 billion in the United States taking care of these patients. So it's very prevalent, the numbers are rising, very morbid, high mortality, high cost burden, and outcomes are less than what you'd expect them to be. So for people like us, there's a lot of job security, but more important, there are other things that we can do to impact all of these things, meaning have better outcomes. And what are those? That's focusing on the comorbidities like we talked about earlier, renal failure and now sleep apnea. If you look at the incidence of various things, including, I was going to speak about COPD later on, but including atrial fibrillation and renal insufficiency, that's about just 30%. If you look at sleep apnea, it's more than 50%. So it's very important to look at these comorbidities, which are not looked at in big major registries that have been done throughout the world. Let's skip over this. So if you look at the big gurus and ask them, how do you treat heart failure? They'll say, okay, you do diuresis, let's reduce the congestion, let's do vasodilation and improve the hemodynamics, let's assess for coexisting condition and see if you can change the trajectory by revascularization, doing CRT and so on and so forth. So part of this is here, and that's what we're going to talk about. Now in heart failure, all of us know that these exacerbations cause a decline in the status. You treat them, it gets better, but it never gets to a point where it was before. And so over a period of time, there's a stepwise decline in the patient's functional activity, eventually leading to death. And is there something we can do to change this trajectory? And the question would be possibly. And the answer would be possibly. So when we look at recommendations from the societies in terms of how do we treat or test for other things, there is a one-liner there that says obstructive sleep apnea may exacerbate heart failure and it might be worth looking into. And they're only talking about oxygen therapy and nothing more when it comes to guidelines. So I put this up there, which is a sawtooth shaped oxygen curve during the night of a sleep apnea patient who was also a heart failure patient, and looking at that similarity with this. And so are we missing a therapeutic opportunity? So we did a study, was called ARIA-1, and this was heart failure patients who came into the hospital, and we said, let's evaluate you for sleep apnea. And all of these patients had elevated BNP, they had LV dysfunction, they had physical exam with volume overload, and so on and so forth. Instead of doing a big full polysomnogram, we ended up doing a mini test where we looked at thoracic impedance, oximetry, and we call it a cardiosomnogram. And this is what it looks like. And this is the oxygen that keeps dipping every time. This is the chest impedance, and you can see as there is the apnea happening, you have a dip in oxygenation status. And we did it right at admission and right before discharge, and in between the patient was medically optimized. So when we looked at these patients, this is just a general population like we usually have when we have heart failure patients, nothing special, high predominance of male patients, and a lot of distribution between hypertensive, non-hypertensive, coronary disease, hyperlipidemia, just the usual. And what we said was we classify these patients into three groups: central sleep apnea, and we'll talk about that as to what it means; non-central sleep apnea, which was an obstructive event or a hypopneic event, and a mixed event. And so this is what a normal respiration looks like, where the breathing is sort of normal and the oxygenation status is normal. With the central sleep apnea, you can see breathing, a complete stop, and then breathing again, and you could see a concomitant dip in the oxygenation. If you look at hypopnea, you can see the breathing, the amplitude of the breathing goes down, but then it catches up again, and there's a concomitant dip in the oxygenation. And this is obstructive sleep apnea with a 4% dip in the oxygenation status, where you can see this reflex hyperventilation when the apnea stops and then it progressively goes down. And this is an obstructive event here, again here, and then this normal sleep. This is a mixed event, and basically it's just pattern recognition. So what we found was that about roughly a quarter of the patients had no sleep disorder breathing, a quarter had mild sleep disorder breathing, a quarter had moderate, and a quarter had severe sleep disorder breathing. If you look at the time in terms of when we found this, these are patients in the hospital. So we analyzed all the times during the time when they were quietly resting, and this can happen in the early wee hours of the morning or in the afternoon when there's no blood draws. It could be any time when the patient gets a break, or during the scheduled night time, which is 11 p.m. to 7 a.m. and other times. And you could see that there's sleep apnea even during what is traditionally waking hours. So sleep apnea can happen pretty much any time of the day. If you take a look and say, okay, maybe just the most severe heart failure patients will have sleep apnea. No, that's not correct. When we analyze patients based on ejection fraction or their filling pressures or their pulmonary pressures, basically we did not find much difference in terms of whether a higher PA pressure predicted more sleep apnea or not. The bottom line is all of these patients need to be screened whether or not they have severe heart failure, and they could be having severe apnea. If you looked at how we got a breakdown of patients, about a fourth of patients had central pure apnea, and about 40% of the patients had obstructive apneas, but about a third of the patients had mixed apneas. So then there comes another myth. Most of my professors taught me, okay, if you treat the heart failure, the apnea goes away. And we proved that wrong. We said, okay, when the patient comes in, within the first day or two, we'll do a sleep study. We'll optimize the patient diaries and everything. And right before discharge, we'll repeat the test. And what we found was it really does not matter. Even though we diuresed these patients more than 4, 5, 6 liters, it really did not matter. A patient with sleep apnea, there may be a little bit of change, but in the big scheme of things, it does not go away. It needs to be treated by itself. So the question is, can we do things, can we treat apnea and decrease the bad outcomes? Can we decrease the length of stay of a patient, which is important? Can we decrease readmission rates? Can we decrease their mortality? And so there's a study that we're trying to do next in terms of bringing these patients in and then randomizing them to various positive airway pressure methods, and we'll talk about that in a second, versus placebo. So the next new thing coming in the treatment of sleep apnea is called adaptive servo ventilation. And basically there's two companies that are making these devices, and they're basically making these devices such as the pacemaker, but this is for breathing. So the device delivers positive airway pressure when necessary. It does not deliver pressure all the time. So there's a more restful evening or night for the patient. It delivers only enough pressure to decrease the apnea or make it go away, but doesn't give undue amount of pressure to make the patient uncomfortable. What does that mean? Here's the CPAP machine and what we call the VPAP machine. So here the CPAP, regular CPAP, it gives the same amount of pressure throughout. And here's the VPAP machine, which can give pressure based on what it determines it's necessary or important. So it creates a target ventilation based on an algorithm. It's a very fancy computer-driven algorithm that delivers positive airway pressure, basically whatever is necessary to eliminate the apnea. And that's how it does it. Most of the times, you just set it and forget it, and it takes care of it. We can go into details as necessary. So there is definitely a reduction in the central apnea index based on these machines. It reduces the arousal and hence the sympathetic nervous activation, significant increase in the deep sleep, and you can see that after the machine is put on, the apnea completely goes away, and this was before therapy. So in the big scheme of things, the bottom line, what is the bottom line? When you see a patient with heart failure, think of sleep apnea. There's a pretty good chance that the patient has sleep apnea. If they have other risk factors, then definitely think about it. And then you start thinking about other things such as how to treat them. There was a study that came out years ago, 2005, so almost 10 years ago, called the CANPAP study, and this was treating sleep apnea, central sleep apnea in heart failure patients and using the CPAP. Now, it was controversial because it ended up showing a no difference in the overall survival. However, it was a controversial study because when they looked at patients whose sleep apnea got better after treatment, those patients did much better than patients whose sleep apnea did not get better despite therapy. So the fault was in the system that delivered the positive airway pressure. And so now there is another trial that's going on called CANPAP 2 using the previous machine that I showed, that hopefully will show long-term outcome that will be better when treated sleep apnea. This is another study that we are part of. It's called a Remede system, and basically it's a pacemaker for phrenic nerve stimulation. And again, the computer determines that you've got apnea. It delivers a little stimulation to the phrenic nerve. Your diaphragm starts waking up, and your apnea is terminated. The pilot study was fairly effective, and now a prospective multi-center study is going on in the US. So in the future, we will have better detection techniques, so you don't have to have a full polysomnogram, better devices that are already in the market right now. And I think the cardiologists need to start thinking about sleep, well, not just for themselves, but for the patients too. And then more studies to be coming out in the future regarding long-term outcomes. So that was pretty much sleep apnea and heart failure. Thank you.
Thank you, Dr. Karia. Yes, there's a question. And while we wait for the microphone, I think one issue is also to differentiate between central and peripheral apnea when we look at the polysomnograph. That is one of the major issues that we have to differentiate.
Is it a question or a comment?
Yeah, no, it's there's a question. It's a quick hints on how to differentiate.
So I skipped that part pretty fast because I had a lot of room to cover. But basically, the two types of apnea, or obstructive apnea and the central apnea, and then the mixed apneas. The obstructive events happen in the general population more often. They're in the obese patients with the short necks and with the lax musculature. These are characterized by a sudden closure of the upper airway because of muscle tone, and a quick opening once the apnea hits, meaning the oxygen level falls, and there's that. Whereas the central apnea is more so an effect of the circulation being impeded because of heart failure, and a decrease in the central respiratory drive, which causes the respiratory muscles not to breathe.
Thank you very much for your interesting talk. My question is there any role of CPAP in patients with obstructive sleep apnea and chronic heart failure?
Yeah, I think that is less debated. There are small single-center studies which have shown that patients who have obstructive sleep apnea who are treated with CPAP have an improvement in LV ejection fraction, have an improvement in quality of life, and so on and so forth. What is more controversial is therapy of central sleep apneas, which is now coming into vogue.
Thank you very much for most interesting presentation on a subject that we always ask ourselves: how do you recognize that this patient or this person has sleep apnea? Because it happens during sleep.
There's a
So
7
how does
out
it
of 10
present?
chance that they have sleep apnea, so you just test for it.
So it doesn't present with it. I mean, it doesn't tell you.
So there are certain strategies that people have used with varying degrees of success. There's something which is mostly used by sleep guys called the Epworth sleep worthiness score, and there's a bunch of questions, about 7 to 10 questions that the patient is asked, and based on the answers you can score it and say you have a high likelihood of having sleep apnea. But the very fact that you have heart failure, you have a 7 out of 10 chance to have sleep apnea. It's better to get tested rather than do any of these scoring patterns. So in my practice, if you have heart failure, you get screened for sleep apnea.
Okay.